Welcome to the Human 5.0 Project, the podcast where we cut straight to the breakthroughs that matter, the show where science meets self-optimization. I'm your host, Ultimate Biohacker 10X, and here we break down the real research, real data, and real dosing behind modern biohacking, from compounds and peptides to techniques, devices, lifestyle strategies, and performance protocols. Most people jump in and jump out before they get the gold, so we're keeping it tight and delivering the essential insights you need without the fluff. If you've taken the time to hit play, we'll make sure you walk away with valuable knowledge that can transform your approach to longevity, health optimization, and beyond. Good morning, loyalist biohackers and longevity rebels. This is Ultimate Biohacker 10X firing up the mic. We are here to stretch your timeline, bulletproof your cells, and make every extra year feel like 20. So, welcome back to the Human 5.0 Project. Today, we are diving into Delta Sleep-Inducing Peptide, or DSIP, a nonapeptide that's been studied for decades across sleep, stress, physiology, pain, and even withdrawal states. And I'm sticking to PubMed-backed facts, no vendor hype, on where it came from, what it's been studied for, where it's been used in the literature, and what the evidence really says. Let's go get it, because you know all of us need more sleep. So DSIP entered the scientific world in the late 70s when the Schonenberger-Monier group in Basel isolated a sleep-related factor from rabbit cerebral venous blood, and it was linked to slow-wave activity. A follow-up paper described the peptide as a nonapeptide and determined its amino acid sequence as tryptophan, alanine, glycine, aspartame, alanine, serine, glycine, glutamine. So yes, DSIP is real, defined, and synthetic versions match the original in early comparative work. So what's it been studied for? Sleep, pain, withdrawal, narcolepsy. So let's go to insomnia first. Sleep quality, mixed but real human trials, okay? There are placebo-controlled human insomnia studies where DSIP was administered intravenously and researchers measured objective sleep outcomes in lab settings. One double-blind matched pairs trial reported higher sleep efficiency and shorter sleep latency versus placebo, but the authors also noted the effects looked statistically significant yet weak, and interpretation depended partly on the placebo group behavior. Other insomnia work and open trials reported improvements in sleep and daytime function, but overall, the human sleep data is inconsistent and mostly older. 2. Pain. Small clinical study, but notable. A small study across headache pain syndromes reported DSIP significantly reduced pain levels in 6 out of 7 patients after a defined injection series. 3. Withdrawal syndromes, alcohol and opiate. One clinical report describes DSIP given intravenously as a sole treatment to patients with alcohol and opiate withdrawal symptoms, with notable limitations like attrition. There's also a paper discussing DSIP use in withdrawal syndromes from addictive drugs, grounded in a mechanistic hypothesis tied to sleep circuitry. Number 4, narcolepsy, case report. There's a published case report in which DSIP injections were given to a 35-year-old male with narcolepsy, with reported reductions in sleep attacks and improved daytime alertness and performance. Important. This is interesting, but it's one person and not a definitive clinical trial. We see this stuff all the time in Reddits and in posts on X and so on and so forth. So, where it's been used. A DSIP-containing preparation called Deltaran appears in PubMed index studies, including clinical, pilot, and experimental work, often from Russian and Eastern European research groups. Example, a pilot trial in elderly diabetic patients reported beneficial anti-diabetic and geroprotective effects, but it's a pilot and not a final verdict. So here's your reality check and the punchline that separates science from marketing. A major review calls DSIP a still unresolved riddle, pointing out that the DSIP sleep factor hypothesis remains weakly documented, partly because there's no clearly established gene or protein precursor or receptor story. So DSIP is not debunked. It's more like real peptide, real studies, but an incomplete biological story, especially by modern standards. Okay, let's get into a little disclaimer here. The content in this podcast and all episodes of the Human 5.0 Project is for informational and educational purposes only. It is not medical advice, diagnosis, or treatment. I am not engaging in medical practice, and nothing said here should be taken as personalized health guidance. Any discussion of supplements, peptides, hormones, medication, diet, exercise protocols, or biohacking practices is based on publicly available research, clinical studies, and general knowledge, not individual medical recommendations. Always consult a qualified healthcare professional before starting, stopping, or changing any supplement, medication, therapy, or lifestyle practice, especially if you have pre-existing conditions, are pregnant, nursing, or taking prescription drugs. Individual results vary widely, and what works for one person may be ineffective or harmful for another. Your health decisions are your responsibility. Thanks for understanding. Now let's get back to optimizing responsibly. There are standard research and clinical dosing protocols from PubMed studies. So historical human trials from the 80s and 90s, and mostly Russian and Swiss, indicate 25 to 100 nanomole per kilogram IV, which is roughly 0.2 to 0.8 milligrams for a 70 kilogram person, as a single bolus before sleep. Most consistent sleep-promoting effects were at 0.4 milligrams roughly. In the chronic insomnia trials, it was 25 nanomoles per kilogram IV daily for 5 to 7 days. In the pain withdrawal studies, it was up to 100 nanomoles per kilogram and sometimes repeated. 2025 real-world peptide community dosing, obviously anecdotal but widely reported. DSIP is sold as a research peptide, nasal spray, sub-Q, or oral capsules. There is no FDA approval at all on this. Subcutaneous form is the most common. For conservative sleep focus, 100 to 250 micrograms a night, 30 to 60 minutes before bed. For moderate usage, 300 to 500 micrograms nightly. And for aggressive usage, which would also include stress or pain or withdrawal, 500 to 1,000 micrograms, sometimes split into AM/PM doses and cycled 5 to 7 days on, 2 to 3 days off, or 4 weeks on, 4 weeks off to avoid tolerance. Nasal spray, 200 to 400 microgram per nostril, which would be 400 to 800 micrograms total, 30 minutes before bed. Reported faster onset than sub-Q due to direct nose-to-brain pathway. Oral capsules, least common, poor bioavailability, 1 to 2 milligrams nightly. The effects are milder. For timing and administration tips, it's really pretty much always pre-bed. DSIP peaks delta wave sleep. So empty stomach is preferred for sub-Q or nasal. Start low, 100 to 200 micrograms. Some report grogginess if it's too high. Safety notes, extremely well tolerated in studies. No serious adverse events at therapeutic doses. There are some rare side effects like mild headache or nausea, paradoxical alertness at high doses, but no known dependency or withdrawal. Bottom line, most users in 2025-2026 settle on 250 to 500 micrograms sub-Q or nasal nightly for 5 to 10 day bursts. Effects build over 3 to 4 nights and cycle off to maintain sensitivity. There is a full DSIP guide and cycle template in the show notes. Stay hacked, stay unbreakable, and stay sleep balanced. I'm out. Thanks for listening to the Human Upgrade Project. If you found value in today's episode, share it with someone who's ready to elevate their biology. Make sure to follow the show for weekly deep dives into peptides, protocols, devices, lifestyle strategies, and the science of high-performance longevity. Until next time, stay curious, stay optimized, and stay 10x.